Hello, my name is Mike Ackerman, and I'm a genetic cardiologist at the Mayo Clinic in Rochester, Minnesota. I also serve as director of Mayo Clinic's Genetic Heart Rhythm Clinic, the Winland Smith Rice Sudden Death Genomics Laboratory, and the Mayo Clinic Winland Smith Rice Comprehensive Sudden Cardiac Death Program. I'm delighted that you chose to join me for today's 35-minute lecture entitled Cardiac Channelopathies: Who Needs an ICD? You know, there is significant need in the community of heart rhythm specialists to increase the competence of healthcare providers taking care of patients with sudden death predisposing genetic heart rhythm disorders, also known as the cardiac channelopathies. We must also increase our confidence in the protective effect of non-defibrillator treatment strategies. Unfortunately, in the United States, an implantable cardioverter defibrillator, the ICD, is being recommended to and implanted in far too many patients with a cardiac channelopathy. We must sound the alarm and get the message out loud and clear, and that message is this: most patients with a cardiac channelopathy do not need and should not receive an ICD. This 35-minute lecture has been designed to do just that. I hope you enjoy it. On behalf of the Mayo Clinic Winland Smith Rice Comprehensive Sudden Cardiac Death Program, welcome to today's lecture on the cardiac channelopathies: Who needs an ICD? These are my conflicts of interest to disclose. I think more important to disclose is what we're going to achieve together today. I'm going to help us determine who needs an implantable cardioverter defibrillator, the ICD, after being diagnosed with one of the three primary channelopathies. This executive summary from 2013 is a really important document in our field, and subsequently, 2 years ago, I had the privilege of joining Dr. Al-Khatib, Dr. Stevenson, and others for this document from the 2017 American Heart Association, American College of Cardiology, and Heart Rhythm Society guideline for the management of patients with ventricular arrhythmias and the prevention of sudden cardiac death, and in it includes our recommendations for the cardiac channelopathies. I'm going to take you to the punchline. Don't leave me though, but when it comes to this question, the answer is no. In other words, the diagnosis of a channelopathy does not equal an ICD. This is really important, and unfortunately, it's really not the case in the United States. Instead, most of our patients are going to be treated pharmacologically, most with beta blockers, and sometimes we choose other medications depending on the channelopathy. And between drugs on the left and devices on the right, there's the role of left cardiac sympathetic denervation, which, although not the focus of today's lecture, I'll touch on it at the end. Our focus instead is going to be on the cardiac channelopathies, the genetic arrhythmia syndromes, and we're going to focus on the big three. I'm going to start with Brugada syndrome and make some comments on which Brugada syndrome patients need an ICD. Then we'll turn to CPVT, and then we'll finish with the most common of the cardiac channelopathies, long QT syndrome. Let's get started with Brugada syndrome. This is not going to be a lecture on the diagnosis of Brugada syndrome, the diagnostic criteria, the latest Shanghai criteria. Instead, I'm going to assume that we are correct in our diagnosis. And you have your patient who persistently shows the spontaneous type 1 Brugada ECG pattern, and you are convinced that he has Brugada syndrome. In fact, your patient is 37 years old, and he shows this ECG spontaneously, and he just fainted in the hot shower. You will recommend a prophylactic ICD. What's your answer, yes or no? Well, in the real world, when we've surveyed this question now for several years, the answer has been 50-50 split. And here the correct answer actually is, it depends. If you and I sized up that faint in the hot shower and we did not like the sound of the faint, we concluded it was arrhythmic syncope, then the answer should be yes, he should get an ICD for his symptomatic Brugada syndrome. If, on the other hand, we had concluded that this is merely a Brugada patient who happened to have a concomitant episode of vasovagal syncope, we should stand down and not give him a prophylactic ICD. So for Brugada syndrome, just a brief word on the diagnosis. The world agrees that if our patients exhibit this type 1 Brugada ECG pattern and faints or tries to die, that's Brugada syndrome. That's symptomatic Brugada syndrome. That's ICD-worthy Brugada syndrome. If more than one family member exhibits Exhibit A, the ECG profile on the left, that's Brugada syndrome. And then if they have a positive genetic test. Now there we'll pause. Stay tuned for a future lecture because we're going to have to unravel the genetics in Brugada syndrome, because indeed the monogenetics of Brugada syndrome is unraveling before our eyes. Back to the ICD, it's a class 1 recommendation if there is a death attempt. 2A, like our patient, if we, as the clinician, as the phenotyper, judge that faint to have been arrhythmic in origin, the debate continues on what we do to further risk stratify the asymptomatic patient. And real importantly, the ICD is not indicated based on family history. Family history is not a personal risk factor in Brugada syndrome. Let's look at that a little more closely then, in a different way. We would all agree a death attempt gets you a class 1 recommendation for an ICD, and you'll get that ICD. Syncope we don't like will get you an ICD in most situations. What about this asymptomatic business and the positive EP study? Should we be doing an EP study? Well, we could have a whole lecture on that, and we won't. I'll just summarize some of the considerations here. Nearly a decade ago, it was thought that an EP study may not be necessary at all for the Brugada patient who's asymptomatic. Later, it was suggested that if we do it, don't be surprised to find inducibility. 40% will be inducible, but that won't be predictive. But I would say now with the latest evidence and the latest way of doing a Brugada syndrome EP study, these are the performance characteristics. With a double stimulation protocol, if we induce VF, that portends a 1.5% chance per year. Is that ICD worthy? We'll have to decide and continue to debate that threshold. But if the EP study, that kind of EP study, is negative, then there's a 0.5% chance per year. I think that's the latest. But back to the patient, even though our focus is on the ICD, I can't resist the urge to give some comments about the therapeutic approach. There is a role for quinidine in symptomatic Brugada syndrome and perhaps the asymptomatic patient who does have a positive EP study. There's a role for RVOT epicardial ablation in the symptomatic Brugada patient who is having ICD shocks. But right now, we should not be doing prophylactic epicardial ablations. And then we need to remember fever as a Brugada trigger and the list of medications that are potentially Brugada dangerous. Well, let's turn our attention to catecholaminergic polymorphic ventricular tachycardia, exemplified by the patient who has exertional events and exhibits this stress test ECG finding of bidirectional ventricular tachycardia. Now, your patient, he's 23, he had a near drowning, and afterwards you did stress testing and you induced that profile, that pattern of bidirectional VT. You have no doubt about your clinical diagnosis in him of CPVT, of symptomatic CPVT, of CPVT that triggered his near drowning. In this setting, is ICD monotherapy indicated or recommended? What would you do? Now, as you think about what you would do, I would just like to share with you that this question has been queried now to thousands of cardiologists, and here the answer has been 80% yes, 20% no. The majority are wrong. The ICD in this setting as monotherapy should never be done. Let's look closely as to why that answer is never as monotherapy in ICD. Before, we need to look at CPVT and just remind ourselves that we're talking about patients with exertion-triggered events, syncope, seizures, cardiac death. Their hearts are structurally normal. They mimic long QT syndrome, but not really. They only mimic it in the sense of exercise-triggered events that conjures up to mind type 1 long QT syndrome. Because the reason it's not much of a mimicry is their resting ECG is completely normal for the most part, and instead they are discovered upon stress testing. Now, importantly, if we wait for this hallmark arrhythmia of bidirectional VT to emerge, we will miss a lot of CPVT cases. I take care of a lot of patients with CPVT, and I can still count on one hand and not use all 5 fingers the number of times in which they have shown the full Monty of exercise-triggered bidirectional VT. Instead, become suspicious in that story in the top right, where upon stress testing in the bottom left, they show you this. Exercise-induced PVCs in bigeminy that kick in at about a heart rate of 110, 120. They may escalate then to PVCs from isolation to PVCs in bigeminy. They might give you a bidirectional couplet, but that is plenty to become plenty suspicious for CPVT, which is the disease of calcium-induced calcium release, for which about 2/3 of all CPVT patients have mutations in one of the largest genes in the human genome, the RYR2 encoded cardiac ryanodine receptor, for which there are mutations scattered from stem to stern that collectively cause a perturbation in the ryanodine receptor, the calcium release channel, making them quote unquote leaky. Of course, that's an oversimplification, but it'll do for now. And that results in diastolic calcium overload, which begets CPVT1 triggered arrhythmias secondary to those delayed after depolarizations. Back to the ICD question, look down at the bottom. That's where I want to draw your attention. Importantly, a class 3, the ICD as a standalone therapy is not indicated in an asymptomatic patient with a diagnosis of CPVT. The standalone therapy class 3 mentioning did not go near far enough, because that should have been stated for every CPVT patient. It should never be standalone therapy. We have been very ICD aggressive in this disease in the past and even in the present. We have been very aggressive in our ICD recommendations and utilization of the ICD in patients with CPVT. If you had an aborted cardiac arrest, you did and often still do get an ICD. If you broke through, or if our patient broke through their beta blocker therapy or didn't like their beta blocker therapy, they got an ICD. If they fainted as their portal of entry to the diagnosis, they got an ICD, even if that happened in an undiagnosed and untreated state. And even asymptomatic patients whose genetic test comes back positive are getting a prophylactic ICD. We need to do better than this. There's clearly today only one definite indication for the ICD on this slide, and that's the aborted cardiac arrest survivor. And stay tuned. There is data emerging that is going to challenge this concept about, do you need an ICD if you had aborted cardiac arrest in an undiagnosed and therefore untreated state? Maybe, maybe not, but more to come on that. But we must do better on the other categories and resist putting so many ICDs in CPVT patients. One of the reasons why is there are cases, not insignificant number, where the ICD has been implicated as the direct cause of death in a patient with CPVT. The electrical storm possibility in this disease is real, and it needs to be counteracted increasingly in our program by triple therapy, as we'll discuss. But CPVT ICD solo therapy, never. Instead, most of our patients are going to be, again, pharmacologically treated, mostly with beta blockers, Nadolol, the preferred beta blocker. There is an established role of flecainide and denervation therapy. In fact, look at the latest guidelines. This is really important. Class of recommendation 1 in patients with CPVT and recurrent events while on beta blocker therapy, treatment intensification with either combination drug therapy, left cardiac sympathetic denervation, and or an ICD is recommended. Did you catch this? It is no longer intensification therapy of those other things after the patient has an ICD. It can be instead of the ICD, and it can be before the ICD. This was a really important advance that the guideline committee has provided those of us who take care of patients with CPVT. Well, let's round the corner and turn our attention now to the most common of the cardiac channelopathies, that of long QT syndrome. And help me with this patient. What would you do? She's 25. She fainted while running on the treadmill. You didn't like the sound of that faint. In fact, you diagnosed her with long QT. You even anticipated type 1 long QT syndrome because of the story, exertional fainting, because of the ECG. You didn't like the broad-based T waves. And guess what? You're right. The test came back 2 weeks later confirming the presence of a KCNQ1 encoded KV7.1 mutation. And her QTC is 503. Will you recommend an ICD for her? Symptomatic. Diagnosis is solid. Now, if you said yes, you would be in good company, because here, after surveying and polling over 1,000 cardiologists, guess what the going rate on this one is? About 2/3, 1/3. 2/3 yes, I would do an ICD, 1/3 no. And again, the minority are correct. The majority is not always right, as it turns out, and they're not right in this query either. You see, I want you to realize that you should and can be absolutely confident in a non-ICD treatment strategy for this patient. Now, what about this patient? In the STEM, I'm going to change one thing only. I'm going to go from LQT1 to LQT2. Guess what? That substitution alone would swing me to seriously considering an ICD for her. LQT1, this storyline, complete confidence in a non-ICD strategy, and you should have that confidence. LQT2, woman, consistently above 500 milliseconds, concerning event. That profile is going to be the single profile where there will be the least number needed to treat to have a prophylactically placed ICD result in a life saved. You must respect LQT2 women. We'll come back to that. But here, this wasn't LQT2. Remember, this was LQT1. Confident, really confident in a non-ICD strategy, not like the 2/3 of cardiologists who would have recommended an ICD. So you have, what's interesting, isn't it? Let's pause here to think. The first scenario, symptomatic Brugada syndrome. That's ICD-worthy Brugada syndrome with the ICD as solo therapy. Symptomatic CPVT, that is treatment-worthy, but never the ICD by itself, and increasingly not an ICD, period. Here, symptomatic LQT1, we don't need an ICD. Confidence in pharmacologic therapy, but if we're LQT2, less confident, and we may be quicker to proceed to an ICD in that person. Tailoring of therapy based upon our patient's phenotype. So for long QT syndrome, we know about it. Future lecture will expose it in more detail in terms of the latest diagnostic, management, and treatment strategies for just this syndrome. But for now, this syndrome affects 1 in 2,000 individuals, and at the heart of long QT syndrome are defective ion channels like loss of function mutations in these voltage-gated potassium channels shown here. We have the big three canonical long QT genotypes of LQT1, 2, and 3. The LQT4 through 17, we can discuss that numbering system at a future time. Very, very minor contributors. It's really about LQT1, LQT2, and LQT3. So for those patients, what do we think about as to when we use an ICD? Oh, there it is. First, we shouldn't be thinking about it. Again, most long QT patients do not need an ICD. They're mostly going to be beta blocker treated individuals and sometimes denervated with left cardiac sympathetic denervation. And even we are starting to consider in certain patients, very carefully selected, about non-therapy, about intentional non-therapy. And to date, this would be viewed as the lowest risk profiled host for long QT. The man, never a symptom past his 40th birthday, QTC at rest, consistently unimpressive, and has a low risk haploinsufficient C-terminal localizing KV 7.1 missense mutation. So even we're moving from an era where we have been quick to implant to even thinking about intentional non-therapy. That's pretty cool. Now for everybody, even though the focus here is again on the ICD, I want to give some comments about an overarching treatment strategy. The drugs to avoid list, really important. And I'm going to show it again, the drugs to avoid list, really important. Potassium replenishment, and if people want to go into complementary alternative medications or the CAMs, fish oil would be a reasonable offering. For that patient, remember with the LQT1, here the guidelines didn't distinguish between genotypes. I would have, but you can see symptomatic was syncope, beta blocker therapy as the class 1, not an ICD, beta blocker therapy. So for beta blocker therapy, it's mostly Nadolol. When Nadolol not available, encourage propranolol, and I would strongly discourage the use of the beta-1 selective beta blockers. Future date, we can go into this in more detail. But for now, I urge caution, don't use these. And for LQT3, our approach is combination propranolol with mixilotine in most cases. Back to the ICD. When do we use it? A death attempt, that is a class 1 recommendation by guidelines. Treatment intolerance or a breakthrough on beta blocker therapy is, but I would argue that we have a much better strategy in that setting, and I would not view a breakthrough event or I don't like my beta blocker, I'm a beta blocker zombie as the route to an ICD. I think we have a better route, that is denervation therapy. What about in primary prevention, predicting the future? The QTC, if it's really long, 550 long, and not LQT1, I'm okay with going more aggressive with an ICD. I don't have to wait for the QTC to be that long in an LQT2 woman, as I mentioned. For me, a woman with type 2 long QT syndrome who's asymptomatic, but her QTC is consistently above 500 milliseconds, I will be thinking hard about an ICD. And if I don't go with an ICD, I'm increasingly thinking beta blocker therapy, beta blocker with mixilotine. That's a new chapter for another day. Or other treatment strategies to optimize their long QT2 protection. In our program, when we've implanted prophylactically the LQT2 woman with a QTC consistently above 500, 1/3 of those women have received an appropriate VT-VF terminating ICD shock within their first battery life. We need to respect LQT2 women above 500. Now, on the other hand, that family history business, we have got to stop implanting defibrillators because of the tragic death of an aunt, an uncle, a cousin, a sibling, a child. Family history is not a personal risk factor in long QT, in CPVT, in Brugada, and we have to realize that what is a canonical risk factor in a different genetic heart disease, which is hypertrophic cardiomyopathy, is not a risk factor in long QT syndrome. In addition, we must break the reflex between an ICD and sodium channel mediated long QT3. LQT3 status does not equal an ICD. We need to become more confident in non-ICD treatment strategies in LQT3, in all long QT syndrome. In fact, let me show you this slide. Oh, there it is. Long QT syndrome does not equal an ICD, and I want you to see where you are. What I'm showing here is I'm aware of programs in the United States where greater than 75% of their long QT patients have an implantable cardioverter defibrillator, the ICD. Whereas on the left are the long QT, on the left are the long QT centers of excellence. Less than 15% of all my patients are being managed with an ICD, and some of those patients I inherited elsewhere. Other programs have ICD utilization rates less than 10%. Now, before you move to the left on this issue, you should ask yourself, what is the survival? What is the outcomes at our programs where we are using an ICD less than 15% of the time? How are we doing? Well, we're doing really well. And in fact, this is a study from one of the largest single center long QT programs in the country and in the world, our program. And you can see our results are very good. If you are asymptomatic, you stay asymptomatic. If you're symptomatic, there are breakthrough events, but these breakthrough events are almost all non-lethal. Our on-therapy lethality rate is nearly 0% over the last 20 years. In other words, when we rarely use an ICD, our outcomes are still great. In fact, you can see that here, the improving outcomes over the years as we all have gotten better and better at risk stratifying, at personalizing therapy, at tailoring their therapy, where the sudden cardiac death rate on therapy is incredibly low, even though we resort to the ICD as part of their treatment just a minority of the time. Now, I told you that I'd make a few words on the therapy juxtaposed between drugs on the left and devices on the right, that of left cardiac sympathetic denervation. I'm going to give you a whole nother lecture in the future focused solely on denervation therapy for the cardiac channelopathy. So this part is just a brief teaser. We've known for a long time of the antifibrillatory effect of denervation therapy, of unilateral left cardiac sympathetic denervation, thanks to Peter Schwartz. And it clearly works, and with that, we have mounted the largest denervation surgical experience around, and we're approaching 300 cases. And look at what the guidelines, this is not just a Mayo Clinic experience, but now codified in the guidelines as of 2 years ago, a class 1 recommendation for high-risk patients with symptomatic long QT where the beta blocker is ineffective breakthroughs, or not tolerated, intensification of therapy with additional medications guided by genotype, left cardiac sympathetic denervation, and or an ICD is recommended. Did you see what took place? The wisdom in this recommendation, I would say, as one of the contributors, is again, the route to treatment intensification does not have to go through an ICD. The other treatments could be instead of the ICD, before the ICD. We have to break this mindset that everything follows after the ICD, and I think this guideline as a class 1 recommendation will help to break this wrong mindset. With this mindset, what are our indications for denervation therapy? Class 1 recommendation, anybody with an appropriate ICD shock, we should be thinking about denervation as a way to make a future shock less likely. Patients who are intolerant to their beta blocker, the beta blocker zombie, or had a breakthrough event, an on beta blocker faint seizure cardiac arrest. Denervation is a class 1 recommendation, and it can be instead of the ICD. The high-risk patient who's asymptomatic, who you're concerned about, class 2B, we've been blessed with a chance to provide this therapy to high-risk patients in developing countries as part of charity care. We are even thinking about denervation as long QT monotherapy, but in very carefully selected patients. Stay tuned on that one. And again, we'll talk all about denervation in its own 30-minute lecture in the future. So let me bring you to the take-home points as we round out this 35-minute lecture. I would want you to leave with this for Brugada syndrome. The patient with a type 1 Brugada ECG pattern and syncope of concern, that's Brugada syndrome. That's symptomatic Brugada syndrome. That's ICD-worthy Brugada syndrome with the ICD as solo standalone therapy. For CPVT, the ICD is becoming the last option in CPVT, not the first, and never, never the only therapy. Number 3, for long QT, most patients with long QT syndrome most do not need and should not receive an ICD. Think Nadolol instead. And if Nadolol is not available, think propranolol. And last, beta blocker intolerance does not have to trigger an ICD recommendation. Think left cardiac sympathetic denervation instead. And if you are intrigued about management of patients with genetic heart disease like the cardiac channelopathies, I would love to invite you to join us in this future course. We have it virtually every October. This is the one coming up next. Come join us. I think you'll enjoy it a lot. And with that, I'd like to thank those entities that have partnered with us, supported us in our efforts to advance our understanding about long QT syndrome, Brugada syndrome, CPVT, and the genetic heart diseases. We could not do it without their support. In particular, the philanthropic support from Wendy's family that has enabled us to strive to heal the sick and advance the science. Thank you for joining me. I hope that these past 30 minutes have helped to increase your competence and confidence when taking care of your next patient with a cardiac channelopathy. The implantable cardioverter defibrillator, the ICD, is an incredible life-saving device, and I have many, many patients who are alive today because of their ICD. Still, a diagnosis of a cardiac channelopathy does not equal an automatic recommendation for an ICD. So before you recommend an ICD for your next patient with a cardiac channelopathy, pause and reflect on whether that recommendation might be not only unnecessary, but unnecessarily aggressive as well. Less than 20% of all my patients have an ICD, and the 80% that are being treated, being managed without an ICD are thankfully every bit as alive as those with an ICD. Well, I trust that you have enjoyed listening to this presentation as much as I enjoyed providing it for you today. If you are interested in learning more about taking care of patients with genetic heart diseases like the cardiac channelopathies, like in the lecture, I now invite you to join me at our next Mayo Clinic Department of Cardiovascular Medicine CME course on the genetics of heart and vascular disease. For more information about this course, please check us out at cveducation.mayo.edu. On behalf of Mayo Clinic's Genetic Heart Rhythm Clinic and the Mayo Clinic Winland-Smith-Rice Comprehensive Sudden Cardiac Death Program, thanks for joining me today. Have a great day.